Perfect. Welcome, everyone. My name is Sean Fitzgerald. I am a staff member with the JDRF Indiana and Kentucky chapter. We so appreciate the time for our three panelists giving us this evening. Tonight, we're going to chat about T1D and COVID-19 vaccines. So thank you for taking some time. Please, as we go through this presentation, feel free to drop questions in the chat. We will certainly take some time at the end to answer some of those. But again, really appreciate them all. And without further ado, we're just going to hop right in. So I'll let them all introduce themselves in a minute here, but just want to give a quick overview of kind of our discussions. We're going to let our three panelists introduce themselves. We are going to kind of talk a little bit about type 1 diabetes and COVID-19 vaccines, just more as a generality. We're going to touch on what JDRF is doing, our recommendations to the CDC on the rollout, what actions JDRF has been taken, and then finally what you could be doing as well as it comes to the rollout. And then I really want to give some opportunities also to hear from Owensboro Health, so some of their insight into what they're doing, their vaccine rollout, what they might be seeing, and again, we are the Indiana and Kentucky chapter, so very, very fortunate to have them joining us as well. Finally, before I turn it over, just want to thank Roche. They help sponsor all our virtual webinars, so appreciate them making this possible. So Dr. Jim Malone, if you want to kick us off and maybe introduce yourself to the group.
Yeah, sure, Sean. And thanks for facilitating and making this possible. I'm really pleased that JDRF is able to put on a program like this with the help of Roche. So I'm a diabetes specialist and currently the president of the Indiana Community Board at JDRF. I've been a JDRF volunteer for about 8 years now, and I'm currently working in diabetes research in industry.
Dr. Dufrayne, if you want to introduce yourself.
Sure, Sean. Thank you for having us. So I'm Fran Dufrayne. I'm a gastroenterologist by training. I've been practicing, as you can tell, for a number of years. I've been in Owensboro for about 8 to 9 years now, and I currently serve as the Chief Medical Officer for the Owensboro Health System. And my role in the discussion tonight will really be talking about our vaccination program.
Okay. And, Dr. Villafuerte.
Yeah, I'm Betty Villafuerte. I joined the Owensboro Health for the past 7 months already. Before that, I was working on a lot of clinical trials for diabetes medication and also doing basic science research on insulin signaling mechanism for the past 25 years in academic medicine, and including beta cell physiology.
Perfect. Well, thank you all again for joining us. I'm going to turn it over to Dr. Jim Malone to kind of kick us off.
Yeah, thanks again, Sean. So I want to provide some background about type 1 diabetes and COVID-19. And a lot of this information is on the JDRF website, and we're going to be showing that at the end of the presentation. But we just kind of excerpt it here, and it is kind of text heavy. So what I did is I highlighted in blue the real talking points. So you don't have to read the whole thing, but I'll just go through sort of the talking points at a high level, so understand kind of where we are and what JDRF's role is in this important disease and this important therapy. So the first is, what do we know about T1D and COVID? Well, one of the most important things is that people with T1D are not at a higher risk of contracting COVID-19. Doesn't mean that it's not serious when they get it, but they're not more susceptible to it than anyone else in the population. One thing that is important is that with any infection, it can really throw off the diabetes control. And when the blood sugars get out of control, especially on the high side, there's a risk of diabetic ketoacidosis. And I think most people with T1D know about DKA and how that's a medical emergency, and we want to try and prevent that at all possible. There is some new information about the effects of COVID in T1D that I want to highlight because these just came up in the last several months. The first one is a study done in the UK that showed that people with T1D are 3 times higher risk of mortality when hospitalized for COVID-19. So when they have serious disease that leads to hospitalization, they're more likely to die than people without diabetes. So that really speaks to the importance and the impact that COVID can have on people with diabetes. And then there was 2 more recent studies, one in the US just published in December, that showed that whether a person has type 1 or type 2, they are also at increased risk, 3 to 4 times risk for severe illness and hospitalization. So not only is there higher mortality, but there's a higher risk of severe illness leading to hospitalization. And then another study out of Scotland really confirmed these findings, that there is a risk of serious outcomes among people with type 1 or type 2 compared to the general population. So these are more recent studies that aren't as well known and really weren't incorporated in some of the factors that led to CDC and other organizations to stratify who is at higher risk. So that's why JDRF is trying to get the word out about these new studies, because they really provide stronger evidence that there is a real risk of COVID-19 in people with diabetes. So let's go to the next slide. So let's talk a little bit more about the vaccine itself and what is the JDRF's position on the new vaccine. Well, first, JDRF is thrilled that there has been an emergency use authorization for 2 of the vaccines that we've heard a lot about recently, the Pfizer BioNTech and the Moderna vaccines. Both of them are now being given across the nation, and we hope to have other vaccines available in the near future. It is important that people with type 1 or type 2 diabetes, as well as their caregivers, have a high priority for receiving the vaccine. So currently they are a priority, but not as high as JDRF would like it. The next is, how do you get the vaccine? Well, the distribution of the vaccine, as you've probably heard, is really run on a state-by-state basis. So although it's shipped with the help of the U.S. military organization, once it gets to the states, each state has their own guidelines, which generally follow the Centers for Disease Control, but it's kind of customized for each state's needs. And so I really encourage you to refer to your own state health department, be Indiana, Kentucky, or any other state, in order to learn what state guidelines are being implemented where you live. Another people want to know, how much does the vaccine cost? Well, as you recall, the federal government paid the manufacturers for the vaccine, so they are given free for all patients regardless of health insurance coverage. Now, I recently had my vaccine, my first dose, just about a week ago, and they did ask me to bring my insurance card with me, not because they needed it to get the vaccine, but there's certain fees that may actually be reimbursed through the insurance. So you don't need to have your insurance, but bring your insurance card with you when you do go get the vaccine. Next slide, Sean. Next is, what are some of the important things you should know about the vaccine? One, is it safe for people with diabetes? Well, yes, the large studies that have been done by the manufacturers in the 40 to 50,000 individuals, those that received the vaccine that had type 1 diabetes did not show any evidence of a safety or effectiveness concern. It works just as well in people with diabetes as those without diabetes. And what about children? Well, the current vaccines have only been studied in people either 16 years of age or 18 years of age. So we don't have adequate data yet to show that it's safe and effective in our younger population. However, both vaccines are now being tested in clinical trials in individuals under the age of, or at age of 12 or older. So between 12 and 16, 12 and 18. And we will continue to monitor the safety and effectiveness. And as soon as that data is available, the vaccines will be made available to those younger people with T1D. Another common question is, does it matter which vaccine I get? Well, the recommendation is no, it really does not matter. They both have a effectiveness in the 95% range. They're very similar in how they were manufactured, kind of the same technique, but they are different. So the most important thing is no matter what vaccine is available, get the one that you can get as soon as possible. Kind of a related question that some people asked, if I get my first dose with one vaccine, can I get the second dose with the other vaccine? Well, there's some differences of opinion about this. I like to follow Dr. Tony Fauci, who is the guru at the National Institute of Health on this. And he recommends that you get the same vaccine the second time, if at all possible. If it's not possible, he says it's okay to get the other vaccine. It's just not as well studied. But again, the most important thing is to get the vaccine, the first one and the second one, preferably the same one, if at all possible. And who has priorities in getting the vaccine? Well, again, the Center for Disease Control has established national guidelines, which the states are making individual decisions on how and in what order it will be distributed to the public. In some states, health systems are utilized to help bring the vaccine to the population in most of need. But again, it really depends on your state's process for distributing the vaccine. So again, check your state's health website to get that information. Another interesting resource that I was not familiar with is the Kaiser Family Foundation has a very good resource of guidelines for each state that you can look up. And the link to this is on the JDRF website. So again, it's another resource to get more information. Next slide. Well, a couple other questions about the vaccine. Do people with type 1 diabetes have priority in getting the vaccine? Well, currently, as you've seen, the way the vaccine is rolled out is the healthcare personnel and residents and staff of long-term care facilities were first in line to get the first doses. And after that, according to the CDC, their next in line was those age 75 and older and other frontline essential workers who fit into this designation are the second group to be vaccinated. This is called phase 1B. The third stage is called 1C, and that focuses on adults 65 years and older, or people over the age of 16 who have a high-risk medical condition, and essential workers who were not included in the first phase. So the committee does recognize that T1D might be at risk of severe illness, but when they made that recommendation, they didn't have the earlier data that I showed you from October and December of this year that shows more conclusively that yes, T1D is at a higher risk. And so JDRF is advocating that people with T1D be put in a higher priority. And this is now being communicated to these agencies. And what is the rationale for this? Well, we follow the data. And when the first recommendations came out, there wasn't solid data about the seriousness of T1D, the seriousness of COVID in T1D. Now there is more substantial evidence, and that's why JDRF really feels that people with both type 1 and type 2 have a more serious risk of complications and should be given a higher priority. The other factor that JDRF is advocating is that COVID-19 has a more serious effect on people of color. And so there are high-risk groups in the community that also have to be considered when you're looking at prioritizing individuals. Next slide, Sean. So what is JDRF doing now? And there's a number of initiatives that I mentioned. One is JDRF has authored a letter about the COVID-19 risks to the T1D community, to the Centers for Disease Control that publishes these guidelines. And because the guidelines don't include the most recent data, which I explained, JDRF is continuing to engage in the CDC, and hopefully we'll see some movement in raising the priority of people with T1D. The JDRF has also provided input into the National Academies of Science, Engineering, and Medicine, which also has been creating a framework for vaccine distribution. So they have more information now about T1D and COVID. And other organizations, JDRF is working alongside with other advocacy organizations with an interest in diabetes, so that more letters are being sent to the CDC urging them to prioritize the needs of people with T1D. Next slide, Sean. So what about the current engagement of JDRF? So we've already discussed that JDRF has provided formal comments to the Centers for Disease Control, emphasizing that recent data, which we talked about. They're working with other organizations to author a joint letter, and they're also doing direct communications to various agencies who are helping to prioritize the distribution of vaccine. And JDRF is also sharing this information with news organizations like Stat News and a publication in Congress called The Hill, so that there's more input into the political community about the needs of T1D in COVID. And so currently the CDC Advisory Committee on Immunization Practices, which really sets these guidelines, are continuing to look at revising their guidelines, and we're hoping that they will reclassify T1D as a higher risk, and also include type 2 diabetes, because that was also shown in the studies. And so JDRF is really advocating that, that the T1D community as a whole be prioritized for the vaccine. Well, what can you be doing in your local communities? Well, JDRF is recommending kind of three things. One, look up vaccine plans in your state. Get familiar with the State Department of Health and what their guidelines and recommendations are. Identify policy influencers in your community. Those news organizations or public health organizations, other leaders, hospitals, physicians. Identify who are the ones that can really influence local healthcare priority and advocate for T1D with those organizations or people. And then look at the resources that are available. The JDRF has a wonderful vaccine access guide, and also a spreadsheet that can show the prevalence of T1D by state. So get to know the facts in your own local states and communities. And then here's some other ideas on how we can influence the distribution policy. Engage social media. If you're part of the T1D community, then advocate for T1D in your social media posting. Submit letters to the editor in your local newspaper. Speak at community meetings. If there's an opportunity to talk about public health, about COVID vaccine, try and advocate for fellow people in the T1D community. And you can always submit comment letters to different government agencies, to your congressmen and women, advocating for more availability of the COVID vaccine to people with T1D.
Perfect. Thank you so much, Jim, for kind of that overview of where we are currently with the COVID-19 vaccines and kind of generally how it relates to the type 1 diabetes community, as well as, of course, JDRF's kind of, take on the current priority system, I think, at least insofar as kind of the CDC recommendations. As you very astutely put it, the recommendations, depending on the state, could go, many different ways, but appreciate you kind of going over that. I do want to kind of bring in our two other panelists at this time as well. Certainly, we'd love to hear their thoughts. I have, let's see if I can move my screen here. There we go. I have some kind of suggested sort of topics that, if you want to kind of touch on, but certainly maybe your general thoughts on what you're seeing at Owensboro Health when it comes to the T1D population. So Dr. Dufrayne, I see you're unmuted if you want to maybe start us off.
Sure. Thanks, Sean. And first of all, I'd like to say that Dr. Malone gave an excellent summary of really where the state of the art stands right now in vaccine, and some of the things I'll comment on or really be kind of re-emphasizing what he's already said. So in general here in Kentucky, first of all, we are following the Kentucky guidelines, which come out of the Kentucky Department of Public Health. And we work closely with the Department of Health and also the State Health Commissioner, Dr. Stack, in one, trying to set up our program, but also trying to influence the policy, just like Dr. Malone said. And I could recommend to people that even for your local hospital, if you can contact your local hospital and see what they're doing on their local level to try and reach out to the state level, because for all of us receiving the vaccine, that's really where the action is happening. The federal government sets the guidelines, the CDC sets the guidelines that come out of the federal government. The federal government is supplying the vaccines, but everything does happen at the state level. So I think that's very important. We started our vaccine program here on December 24th. And since then, we've already vaccinated in our area. We've given out about 13,000 vaccines, including 4,000 second doses. I've already had my 2 doses. They went well. I had really no problems. Both shots, my arm was a little sore for 24 hours. Other than that, I did fine. Some people, particularly with the second shot, will let you know that they actually can feel a little sick, little headache, a little fatigue. Nobody I know really has missed work from it, but you'll feel probably some mild symptoms. And we do now recommend, when it first came out, they said, oh, take Tylenol or Advil before you get your shot, or Motrin, and now we know don't take it for at least 12 hours. So I want to really emphasize that. So, and we're afraid if you take it, it's theoretical, we don't know yet, but if you're taking something to suppress your symptoms, are you suppressing your reaction? And that's what you want. You want a good reaction to the shot. So those are some of the highlights that we've learned here. We've had no serious side effects or complications. And like I said, we've done over 13,000 so far, and it's really gone well. I want to speak to the importance of the T1D population getting the vaccine, and I strongly support that. Frequently, so first of all, the Advisory Committee on Immunization Practices, like Dr. Malone was saying, you have to keep in mind that policymakers their policies always lag behind the data. So there are new studies out there now which are going to change the policies, and it'll take a little while for that to catch up. But lobbying, just like Dr. Malone said, really would be very helpful. And I anticipate some things changing. So right now we are in phase 1B. The state of Kentucky says we'll probably go to phase 1C, probably in the beginning of March. And that for us will be 60 and above. And then the phases after that will be 40 and above, and then always in those conditions, in those patients, particularly those who have some underlying risk factor, and diabetes is an underlying risk factor, not for necessarily getting the infection itself, but they're really at risk once they have the infection. So we're very concerned about that population. And I can see the recommendations changing some. So rather than a healthy 40-year-old getting the vaccine in the next phase, phase 2, maybe we start to bump up other groups of people. Your people with emphysema, your people with type 1, type 2 diabetes. So I anticipate there may be some policy changes going along. Your next question, how is the rollout going for the vaccine? Here, it's going very well. We luckily had some time to anticipate that the vaccine was coming, so we were able to set up a fairly good program, and we've had a very good response to the vaccine. What should people know when scheduling? So at least here in Owensboro Health, we can schedule online. And the first thing you'll see when you go to schedule, it's going to ask you some questions, and those questions will serve as a screening tool. So right now, the questions really are based on age. If you're not 70, it will redirect you to another page where it puts you on a waiting list. But if you meet the criteria, it gets you right into the schedule, and we schedule you as quickly as possible. As the other phases are rolled out, those will add some more questions. And eventually the questions will be, do you have any underlying conditions that may make you more at risk for this? And I anticipate it being, do you have diabetes? Any form of diabetes. We're really not distinguishing between type 1 and type 2 at this point. We view anyone with diabetes as having an increased risk for suffering from the disease, so we don't really differentiate. So that's really the state of what's going on over on the Kentucky side. And I'll hang about for any other questions or anything that comes up from your chat. And then I'll turn it over to Dr. Villafuerte.
Thank you, Dr. Dufrayne. And then before we turn over to Dr. Villafuerte, I do have one question in the chat, just asking, so you mentioned, could you just reiterate the question about, or recommendation about not taking aspirin or Motrin, anything after receiving the COVID-19 vaccine?
So early on, because they were anticipating that some people may have a reaction to it, what was recommended was before you get your vaccine shot, maybe you should take a dose of Tylenol or Motrin. We now know that's not the thing to do. So we recommend taking no medications like any painkiller, any Motrin or Advil or Tylenol or aspirin. Do not take that medication prior to the shot, and preferably you wait about 12 hours. And that's about the time if you're going to have some symptoms from the shot. And symptoms are not a bad thing. It doesn't mean that you got COVID. It just means your body's responding in a very favorable way. And we want that response. But if it gets to the point that you're really uncomfortable about 12 hours after the shot, then go ahead and take Tylenol if you can take it, if there are no allergies. Take a Motrin or an Advil if you have no problems taking those. And then that'll help you feel better and probably sleep through the night.
Perfect. I appreciate you saying that, and thanks for asking that in the chat, Darlene. Want to turn over to Dr. Villafuerte if you want to give some of your thoughts as well. Thank you. Let me hear. You're on mute right now, Dr. Villafuerte. Are you able to unmute? Oh, there you go.
Can you hear me now?
I can hear you now. Perfect.
Good, good. I think we should know historically the reason why type 1 was not prioritized for the vaccine is because the initial data coming out of Italy and China showed that surprisingly, there's very few type 1 patients who contacted COVID-19. And at first, they thought it's an immune mechanism that is involved that protects type 1 patients from getting the infection. But in fact, it's all because they're all hiding and being protected by the family and preventing all the exposure. But now we have all the data coming out of England and Scotland and United States itself showing that in fact they do not do better, they do much worse. For example, CDC showed that the mortality rate of a patient who contacted COVID-19 averaged around 6.2% if they do not have diabetes. But with diabetes, the mortality rate goes up to 28.8%. And if they have diabetes and are out of control before they get the infection, the mortality rate is as high as 41.7%. Now, this data lumped together both type 1 and type 2 diabetic, and we know that most of the patients will have type 2 diabetes. But as you mentioned before, Dr. Malone mentioned that the Scotland study and English study did show, in fact, the mortality rate is much higher with type 1 diabetes compared to type 2 diabetes. For example, in the Scottish study, the odds ratio of getting fatal COVID infection is 2.39 for type 1 diabetic and 1.36 for type 2 diabetes. So there's a significant difference even between the two types of diabetes. And mortality, higher fatal infection is related to whether they're male, if you are a male, if you live in a residential care facility, if you have the complications of the type 1 diabetes like retinopathy, chronic kidney disease, and if your hemoglobin A1C is over 10% at the time that you get COVID infection, or if you were hospitalized for DKA or hypoglycemia within the last 5 years, or you're getting a lot of medications for your diabetes, that increases your risk for getting fatal infection. And the United States study showed that 50% of patients with type 1 diabetes mentioned that their blood sugar become very hard to control when they get the infection, even if they were not hospitalized. And 1/3 of patients was hospitalized for subsequent DKA. So there is still a lot of residual medical problem. In terms of the risk for fatality, the English study showed people who are type 1 diabetic who are older than 70 years old, if they are non-white, they have previous stroke, history of congestive heart failure or kidney failure, and if they are poor. So socioeconomic deprivation appears to be a significant factor in contributing to severe COVID infection and fatality, even for type 1 diabetic. Now, there is also another scenario coming out right now. Some people are developing new onset diabetes with severe COVID infection. We're not sure whether they'll end up to be a type 1 or type 2. Maybe it's the virus entering to the islet cells through the ACE2 receptor that leads to accumulation of viral particle in the beta cells and cytolysis or destruction of the cell. that may be a mechanism that's contributing to new onset diabetes. Another possible mechanism is partial release of the antigen to the circulation, leading to the same mechanism as type 1 diabetic, getting an autoimmune disease because of the release of antigen. We're not sure yet how these people will end up. And also there's some higher incidence of pancreatitis or inflammation of the pancreas if they have severe COVID-19 infection. So there's a lot of elevation of amylase and lipase. So it looks like there should be actually a priority for type 1 rather than type 2, but it seems to be, even though the data came out of CDC showing higher mortality rate, they still put type 2 as a higher priority compared to type 1. Any question?
I really appreciate you sharing that, and that I had not heard that kind of that people were after contracting COVID, you know, seeing the sort of types of newly diagnosed onset. So I appreciate you sharing kind of some of those studies and the insights into that. So thank you, Dr. Villafuerte. I think, you know, to your point, I think that's the perfect segue to maybe opening it up to some questions at this time. Elizabeth says thanks to the panelists. Thank you, Elizabeth, for joining. I do have my coworker Lindsay sent me a couple that she's gotten on Facebook, so I can definitely start off with some of those. But if anyone who's on the Zoom, feel free to drop them in the chat as well. Funny enough, Dr. Fuerte, one of the questions was, how can we schedule with Dr. Villafuerte? How can we schedule with you?
Call 270-688-3500. Sorry.
There you go. Just give her a call and you can schedule with her. So I thought that was a perfect question for you. Another question, and by all means, any of our panelists feel free to hop on and weigh in on any of these. Is there any reason a type 1 diabetic shouldn't get the vaccine?
So I can speak to that in general, and that is there are very few contraindications to receiving the vaccine. So if you have a prior known allergy to anything that's related to the vaccine, and there is some concern with people who've had anaphylaxis to any vaccine, so that's not an absolute contraindication. And other than that, specifically addressing type 1 diabetics, no, there's no contraindication that's related to their diabetes that would prevent them from getting a vaccine. We would still strongly recommend that once it's available to get it. And then one thing I would be remiss if I didn't mention it is, until you get the vaccine, and even after you get the vaccine, you should still social distance and wear your mask and wash your hands and stay out of crowds. That's the most important thing. I got my my second dose of my vaccine 2 weeks ago, and I still wear my mask everywhere I go. And because the vaccine does not necessarily prevent you from exposure to the virus, it just helps you to not get as sick. So that's really what the data shows. So still do the things that we strongly recommend. And like Dr. Malone said, Dr. Fauci is the science guy. He's the data guy, and he has been proven to be correct in this. The thing that I am really amazed at is prior to COVID, every year about this time, we'd be inundated with flu. And at our hospital, we have not had one flu admissions yet this year, whereas by this time we'd be in the hundreds. So social distancing, wearing a mask, washing your hands, doing all the things we recommend not only protects you against COVID, it protects you against the flu. So it works. Our
our next question, kind of related, are vaccine side effects worse for type 1 diabetics?
Yeah, my understanding is that the side effects are no different. They're mostly mild. Sometimes the second injection may be a little bit more, maybe a few more symptoms than the first one, but as Dr. Dufrayne said, that's a good sign. That means your immune system is working and you're getting good result. So no concern about increased side effects if you have type 1.
And that has also been our experience.
A question from, let's see, here in Zoom, Andrea asks, do we know anything if there is any risk of a type 1 diabetic not being able to safely go through pregnancy with receiving the vaccine? So certainly as a type 1 diabetic, but then maybe more generally, I'm also curious if there's, pregnancy and the vaccine in more general. Because I was reading, it's a very not taken part in clinical studies as much as maybe it should be, kind of the pregnant women population. But any thoughts on that question?
And you're right, it's really hard to do these type of studies involving pregnancy. So it's much more difficult to do. I can tell you, coming out of the ACOG, the American College of Gynecology, they recommend that you get the vaccine even if you're pregnant. And there's been no contraindication and no studies out there saying that getting the vaccine will affect fertility at all. So, and that was a big concern early on, even amongst our nurses, because people were really talking about that, oh, if you get the vaccine, it's going to affect your fertility and give you other reproductive issues. And none of that has been shown to be true.
Dr. Villafuerte, were you going to add something?
Yes, in fact, COVID-19 can be very severe in pregnant women. So it's best to have the vaccine now before you get pregnant, or it's recommended by the CDC at phase 1C to vaccinate pregnant women. So it's highly recommended to do it before you get the infection. The infection, it's much, much worse.
Perfect. Thank you, Andrea, for asking that question. Another one from Facebook. Did I understand correctly that someone who might have retinopathy or potentially caused by diabetes or possibly not is at a higher risk of complications?
That came from the Scottish and British study. They showed that patients with anybody who has complications from diabetes, it means it's less well controlled, including retinopathy, chronic kidney disease, on dialysis. Anybody with complications, this type of complications is associated with actually higher fatality rate.
Yeah, and that stands to reason, right? Complications begin complications, unfortunately.
Right, exactly.
Thank you. After getting vaccinated as a type 1 diabetic, is there anything we might need to worry about?
Not that I'm aware of.
Yeah, I think there's some confusion on the mechanism by which autoimmune disease develop. When you develop an autoimmune disease targeted towards your islet, it is only specific for the islet cells. It does not affect your overall immune function. So the rest of your immune response to virus, bacteria, etc., will all still be intact.
Perfect.
It should not theoretically affect your, your diabetes control, the natural course of your autoimmune disease. It should not.
Great. I have two questions kind of relating to, I think, the advocacy efforts we've touched on a bit. First asks, I think I heard that JDRF nationally is lobbying the CDC regarding prioritizing diabetes, which is correct, Tim. is Indiana and Kentucky JDRF lobbying our specific state health departments, since these decisions are being made on a state-by-state basis? I'll just start off, and by all means, I'll let our panelists weigh in. JDRF is not is a nonprofit, a 501c3, so we don't engage in kind of lobbying on a local level in any way. What we do locally is empower and strongly advocate for kind of our families and people to contact and make their voices heard, right? We're about empowering the T1D community. Our JDRF advocacy team in DC is the one that kind of lobbies CDC as well. So I just wanted to add that, but I wanted to toss that to the panelists. Any thoughts on that?
Yeah, my thought, Sean, is that type of advocacy is perfect for volunteers of JDRF, because at the local level, the politicians and those in authority really want to hear from the people in their own districts, and not necessarily from an organization who, like JDRF, is focused on T1D. But if they hear from their own constituents, that has more weight. And so I think that's where individuals can really do some lobbying on their own, and that would be actually more helpful than a big organization like JDRF.
Yeah. And as a follow-up to that, Elizabeth asked, and maybe Dr. Villafuerte or Dr. Dufrayne can weigh in on this, does anyone know if our local Kentucky endocrinologists and doctors are lobbying the governor of Kentucky and Dr. Stack?
Not that I know of, you know.
And I was going to say the same thing. I don't have a specific, no, I don't know of anyone specifically who's in the lobbying.
Let's see. Looks like we have one last question. And certainly we start off by kind of highlighting the vaccines currently are kind of skewing, 16 and older, right? So one question was, obviously now, like younger people, particularly younger type 1 diabetics, might be needed for clinical trials. So any suggestions on how we can get our younger T1Ds in potential clinical trials?
I think both Moderna and Pfizer are just starting to recruit patients between 12 to 16 or 18 years old. They're starting the study. I think because of the, pediatrics department, they're all asking for this study to be conducted immediately. So they're just starting the study.
I'll just add JDRF, I believe it's jdrf.org/clinical trials, has a great website that you're able to go to, has some screening questions and shows, what clinical trials you might be eligible for your child in your area. So that might be a good one to take a look at as well. So at this time, I don't see any other questions. So I'll certainly, if any of you have any closing thoughts, otherwise I'll kind of take us home and close this out here.
Well, I just want to thank my fellow panelists from Kentucky for joining me in this very rich discussion. Both of you really added a lot. So thanks for participating and answering questions. And I hope we do more of these educational programs. I find very stimulating and valuable for all of us.
Thank you.
Oh, Dr. Dufrayne, you're muted. I want to be able to hear you.
There you go. I would like to thank you for having us. I've learned a lot participating in this, and with the pandemic, we've really have switched to this kind of form of communicating and education and learning, and I think it's really been a great addition. So I would like to thank you.
Thank you for having me also. Thank you.
Of course. Well, thank you so much to our three panelists. So appreciate you joining us this evening. For all those who were able to join us, whether on Zoom or Facebook Live, the slide deck will be made available to those who attended on Zoom via email, and then the recording will be available on our Virtual Connections webpage, along with all of our upcoming webinars and events. So please check that website out as well. So thank you all so much. Have a great rest of your evening, and please continue to stay safe. Thank you.
Thank you. You too, Sean.
Thank you.
Thank you.